acute COVID, but rather long COVID and its respiratory effects. And how does this impact our athletes? So if we look at coronavirus itself, right? So the coronavirus 2019, or COVID-19, as so many of us call it, we know it's caused by the severe acute respiratory syndrome coronavirus number 2. Obviously, all of this is quite a mouthful, so it has been shortened to be called COVID-19. It started in December in China, in the city, the capital of Hubei. It started in Wuhan, and by March 11, the World Health Organization had declared it a pandemic. Jamaica, not to be outdone by anyone else, of course, recorded its first case just before WHO declared it a pandemic, and we had our first case here in Jamaica identified on March 10. And you would have to be living, I don't know, on the moon or on Mars not to recognize how much COVID-19 has impacted every sphere of life, and has no doubt caused unprecedented morbidity and mortality globally. This is not advancing. Just hold just a second for me, please. It has not advancing. Share again. I'm sorry for the glitch, a bit of a technical hiccup right here. Let's see if I can get it sorted out. So, okay, hopefully this will work. So long COVID, the actual description of long COVID is a patient-driven initiative. And it was a support group called the Body Politic COVID-19 Support Group that conducted the research and found out that the rhetoric that was being bandied about, that persons will be better from COVID after 2 weeks, realized that this was not the experience for a majority of persons. They realized that there was actually indeed a large subset of patients, many of whom were young and previously healthy, who will way beyond this 2 weeks continue to experience symptoms. And out of this, we have come to recognize that beyond the acute infection of COVID-19, there is actually a post-infectious period. And it has been referred to by a wide range of names: post-acute COVID-19, post-acute, post-COVID syndrome, long-term effects, long COVID, long haulers COVID. And because you have this plethora of names, sometimes the recognition of what is taking place and a uniform descriptive term makes it difficult to actually capture the number of persons actually experiencing this post-infectious sequelae of long COVID. Not only do they have various names, but so far too, there has not been much consensus on actually what is long COVID. So the NICE, or the National Institute for Health and Care Excellence guidelines, say that long COVID is an ongoing symptomatic COVID-19 for persons who are having symptoms between 4 and 12. So that is ongoing COVID. And post-COVID, according to this group, is for persons who still have symptoms for more than 12 weeks after the start of having acute symptoms. A little confusing to separate it into ongoing and post-COVID, but that is the suggestion by the NICE guidelines. CDC has said that there's long COVID, which is a range of symptoms that can last for weeks or months. So here that they have not given any particular number, and this or maybe associated with multi-organ effects, because it can have effects on the heart, the lung, the kidney, the skin, the brain. And these multi-organ effects can also include conditions that occur after COVID-19. They too have looked at the effects not just of the virus itself, but of COVID-19 treatment or hospitalization. WHO has made it has simplified it somewhat. And WHO says long COVID occurs in individuals who have had a history of probable or confirmed SARS-CoV-2 infection. So it's not just those who are confirmed, but also probable infection, and usually 3 months from the onset of COVID-19 symptoms. These symptoms last for at least 2 months, and there is no other explanation, no other alternative diagnosis that can explain why the person is experiencing the symptoms they are having. The symptoms may be new. They never had these symptoms before during the acute COVID-19, or maybe symptoms that persist from the initial illness. And we have recognized too that symptoms may fluctuate or relapse over time. So you have patients who may have had a skin rash with the acute infection. The skin rash now disappears, and 6 weeks after the acute infection, they're having a recurrence of the skin rash. Still, we can't fully explain what is going on. So for the purpose of long COVID, we will adopt the WHO definition. And what this diagram here is doing is just putting it in a spatial reference. So first, week 1 and week 2, what we're having is an actual viral infection. And during these 2 weeks, this is when our tests, such as our PCR, are often positive, having done an adequate nasopharyngeal swab. But by the end of the 3rd week, entering into our 4th week, the chance of isolating the virus is so much smaller. And it is likely that if a test is done after 4 weeks, the PCR may come back negative. Yes, we've known persons who have had positive PCRs for much longer, but generally speaking, the PCRs come back negative. And it is in week 4 that it is thought, okay, is this ongoing COVID-19 or is this subacute COVID-19? By the time we hit week 4 too, we may be seeing multi-organ effects that we never saw in the initial phases of the infection. And definitely by week 12 and into the 6 months going on, there's a whole plethora of symptoms that can occur and have been so put under the umbrella of long COVID. And I like to think of it as a head to toe. Some of the more common symptoms would include the fatigue, profound fatigue. You've had patients who have had to reorganize where they sleep because they just cannot climb the stairs to go up to their bedrooms. So there's a significant decline in the quality of life. There may be muscular weakness, joint pains, muscle pains, shortness of breath, cough, chest pain. A person may still be requiring oxygen. There may be the cognitive abnormalities that we see: anxiety, depression, sleep disturbances. Many patients describe insomnia. There may be PTSD. And there's this feeling of brain fog where persons just have to focus for a longer time to complete tasks that prior to COVID-19 they had no difficulty doing. There's the palpitations, the chest pain I had mentioned, and even outside of the acute COVID-19 infection, there's a real risk of having thromboembolism. These are clots within the limbs, legs, but more so clots within the lungs, which can be fatal. Kidney disease, we've seen occur in persons who prior to COVID-19 had no evidence of renal impairment. And then there's the alopecia that can all occur within this long COVID or post-COVID period. So how prevalent is it? Seemingly, because as time elapses, we recognize that there are even more symptoms being recognized as belonging to the long COVID or the post-COVID syndrome. And a number of patients are reporting long COVID symptoms. This number is increasing. And as Dr. Ratcliffe said, it can occur in patients who were asymptomatic. So they had a test, maybe they were a contact or maybe a probable, and these patients were asymptomatic for the acute illness, but now they're having symptoms which cannot be explained by any other factor and are being labeled as having long COVID syndrome. So varying severity of disease is not only those who have had severe disease, but the asymptomatic, the mild, the moderate are all at risk. The UK has really led the charge in this area, because they do have a registry where they record symptoms, and yes, all persons may not be captured, but this survey by the UK government's Office for National Statistics in 2020 recognized that 1 in 5 persons who had tested positive for COVID-19 still had symptoms beyond 5 weeks. And 1 in 10 persons had symptoms lasting for 12 weeks and longer. And right now, there are about 2 million persons actually included in the UK government's Office for National Statistics as having long COVID. So it is not to be scoffed at. When we speak about the syndrome, we're speaking about persons experiencing acute and post-acute, well, not acute, but the post-acute effects of COVID-19. We do recognize that there are a number of factors, though, that may sort of cloud or recognition of what is going on. Is this prolonged acute infection? Is this a person who is now depressed and anxious because of the social isolation that may have occurred? Is this a completely different diagnosis? We may have unmasked pre-existing health conditions that were not adequately managed or even sufficiently identified prior to COVID-19, and now we're seeing the effects of these. Or is this a reinfection, as we know may occur? Some of the symptoms that we see in this post-acute phase may actually include effects of COVID-19 treatment, particularly those who had severe illness, may have been admitted to ICU. They may be having severe muscle weakness because of post-ICU intensive care syndrome or muscle deconditioning. There's a post-traumatic stress disorder. When you have somebody isolated for 4 weeks, 5 weeks, 6 weeks, as we've had in Jamaica, no doubt this has an effect on their cognitive function and their psyche. And then there's the side effects of medication. One of the drugs that we commonly use would be steroids, and steroids can affect muscle function, can contribute to muscle deconditioning. We know that it can cause anxiety and depression in some patients. So before we label the symptoms that someone is having as being long COVID, we need to rule out. So it is a diagnosis also of exclusion. We need to rule out that there may actually be another cause for what we're seeing. In 2020, Carfi et al. Published in JAMA the Association of Post-COVID Symptoms in persons who during the acute phase would have had particular symptoms. So what we see is in the acute COVID-19 phase, those persons who had fatigue are also in the post-COVID phase are very likely to have significant fatigue as well. Dyspnea, which is a common symptom in the acute phase, many times in the post-COVID phase, these persons would be at increased risk of having ongoing dyspnea. The cough, common in the acute phase, is less so in the post-COVID, but we still do see it. And the myalgia, the muscle pains, which tend to be quite common as to the lack of appetite, and the headaches are less common symptoms in the post-COVID, but they do occur. So in patients who had recovered from COVID, at least 87.4%, that's a large number, report persistence of at least one symptom. And 12.6% were completely free of any COVID-19 related symptom, while as high as 32% had one or two, and one study actually showed 55% having 3 or more symptoms. So no doubt, long COVID is affecting the quality of life of many persons. So why would somebody develop long COVID-19 syndrome? It remains unclear. The type of symptoms and the number of symptoms at presentation, which the previous slide would have outlined, may indicate the risk of a prolonged course. A high level of physical fitness may actually be protective against the risk of severe disease requiring hospitalization, but it is unclear if this modulates disease course and recovery patterns in mild COVID-19. And what is becoming obvious is that many of our athletes who do have a high level of physical fitness, who may not have been admitted to hospital because of COVID-19 infection, because they had mild disease, but yet post-COVID, during this long COVID period, it is negatively affecting their performance. So the pathophysiology is largely unknown. We do not know why some persons' recovery is prolonged. There have been various theories put forward, whether it is due to persistent viremia due to weak or absent antibody response, relapse or reinfection, whether it is inflammatory based, deconditioning of the person, and then mental factors all have a role to play. There has been looked at the inflammatory response taking place, and we do know that a dysregulated inflammation has a key role in the pathogenesis of not just acute, but also post-COVID manifestations. There may be a hyperinflammatory acute phase with markedly elevated inflammatory markers, leading to vascular dysfunction, endothelial injury, which may contribute to what we're seeing in this post-COVID or long COVID period. And what are the risk factors? While we have identified that a high level of physical fitness may put someone at a lower risk of having acute, severe acute COVID, the risk factors for having long COVID, the severity of the illness, so the more severe the illness is, the more likely the person is to have long COVID. If the person has had a pre-existing respiratory disease, so even though when COVID first started, we thought persons who have asthma were at a higher risk, it is now shown that persons who have asthma, particularly asthma that is controlled, are not at any higher risk of having acute COVID, but they may actually be at a greater risk of having long COVID. Persons who are overweight are also at risk. Older persons, Black, Asians, and other minority ethnic groups have been identified as being at risk, and so too have women. And as I mentioned, it could be a head to toe. So you have a multi-organ system involvement, and you may have an overlap of systems being impacted or affected in someone who has long COVID. So you have the pulmonary, and we mentioned the chest pain, the dyspnea, the clots that may occur. There's a hematological, there's a cardiovascular risk with the arrhythmias as the irregular heartbeats or inflammatory myocarditis. The renal, so you may have acute kidney failure or kidney injury. Endocrine, there is a higher risk of developing diabetes, not necessarily associated with the use of steroids, but certainly this too may contribute, as well as thyroid abnormalities. Gastrointestinal and hepatobiliary systems can also be involved. You may have hepatitis on the background of a previous COVID infection, ongoing dyspeptic symptoms and diarrhea. Dermatological, there are rashes associated, and the neuropsychiatric I would have mentioned before. This is the depression, the anxiety, the insomnia, ongoing headaches, and as well as strokes. So it is a multi-organ system involvement that we are seeing. And even though our athletes are fit, and therefore we have not really had athletes, yes, we've heard of some athletes who have developed myocarditis within the acute phase, but we're really not expecting many of our athletes to have severe disease and therefore to have long COVID. So while the COVID-19 illness does not appear to be associated with protracted symptoms, it's acute in the majority of athletes, up to 10% of athletes that were looked at in this study at a month following the onset of symptoms remained symptomatic, had some issues, which is somewhat similar to the general population. So the COVID-19, while it may not have been severe for many of them to be admitted to hospital, is having an effect because of this ongoing symptoms with the athletes' full recovery and return to their profession. I'm just going to mention a few. There is Zola Budd. So she, I gather, is famous for her barefooted running. And fine, Zola Budd is 54 years old. So she's not one of our younger athletes, but she has been quite vocal in underscoring what long COVID has done for her. She did write, it was 4 weeks since she had a positive test and 3 weeks since she was having symptoms. She decided to run again, and she was having increased heart rates that she was acutely aware of. And she underscores how prior to COVID, how her heart rate would recover within a minute, but now it's taking 4 minutes. For the average person, that is so what, but definitely for an athlete, this underscores, is she fit enough to participate? Is she fit enough to continue training? Is there a risk of injury or further illness if she continues so? And she knows it because she knows what she felt prior to COVID. Chris Silva, the Wealth Triathlon, younger than Zola Budd. So we thought it may have been a feature of age. He's 30 years old. He writes that long COVID symptoms were so severe, he thought he may never recover. And you can imagine what this may mean to an athlete. He had only mild symptoms at first, but he felt that he may have returned to training too soon. And he had a 10-month battle with long COVID and how he felt it was affecting his performance. And we have other athletes. We have footballers. We have NFL players. We have WNBA players, all of whom have been negatively impacted. And these are professional athletes. Some may consider them elite athletes, where this is their means of livelihood. And if it is that they are unable to work, they are unable to perform, it is going to have a ripple effect, not just on their pocket, but also on their mentation. And how is this impacting? And so for many persons, it was like, but we don't expect to see this in our athletes. So no doubt, long COVID is not anything to scoff at. It is having a profound effect on the return to function of our professional and elite athletes. So if we look particularly at the respiratory manifestations of long COVID, let's see what happens here. So we have a spectrum of pulmonary manifestations that can occur in the long COVID period. Dyspnea, shortness of breath, is the most common persistent symptom. And it can be so severe that some persons just walk a few feet, a few yards, and they feel the need to stop, to rest, to sit, because of how severe the shortness of breath is. You may have persons who, despite no longer having acute COVID, still require supplemental oxygen. 4 weeks, 5 weeks, 6 weeks after the acute COVID, they're still on oxygen. It may just be 1 or 2 liters per minute. But the moment you turn that oxygen off, their oxygen saturation levels plummet. And then you have the subset of patients who are in the ICU, who there is a difficulty in weaning them off the ventilator or weaning them off the high flow nasal oxygens. And you turn it down and you gradually turn down the numbers, and there comes a point where you think, okay, this person may be safe enough to come off. We've ruled out any other underlying infection or electrolyte abnormalities, but yet it takes weeks sometimes to get them off a ventilator or get them off the high flow, non-invasive oxygen machine. Estimates from studies suggest patients with greater severity of acute COVID, particularly those who had to be admitted to an ICU or received non-invasive mechanical ventilation, these are the persons who are at highest risk for long-term pulmonary complications. And I am seeing them. I see the persons who come in and just to walk 25 feet, 15 feet, they are so dyspneic. Then there's a pulmonary vascular microthrombosis and macrothrombosis that can be observed in as much as 30% of patients with COVID-19. And this number tends to be higher than any other critically ill populations. Hence why some persons during the acute COVID-19 empirically put patients on antiplatelet or even antithrombotic agents or anticoagulant agents. But we recognize that even weeks after COVID, someone can have significant shortness of breath, not just due to deconditioning, but due to microthrombi or macrothrombi. So I had a lady who came to my office and she stepped inside, and this is a younger woman. She was 36, or she is 36, thankfully. She is, and not a was. She's 36 years old. Yes, she was obese, and she walked inside and she said she had COVID. She was not admitted to hospital, but now she's having severe shortness of breath. And this lady turned out to have multiple clots in her lungs. There's another gentleman that I know of. He's not obese. He's not overweight. He exercises regularly. He tells me he's at the gym. He too did not require admission to hospital for COVID-19, and he too developed clots in his lungs. So this is something we need to be mindful of, that someone in the post-acute COVID having shortness of breath, we need to remind ourselves that it could be due to the background of clots within the lungs that may have formed inside too. Oftentimes clots in the lungs come from the limbs that break off and travel to the lungs, but the clots
Dr. Baker, you've muted yourself, I think. Not hearing you.
Sorry, I think it said the host muted me, so I was wondering what was happening. So anyway,
Oh, sorry.
no, that's okay.
Sorry.
So the clots associated with COVID-19 in the long COVID phase, unlike many of the other clots that start off in the limbs and then travel to the lungs, these clots may actually form inside within the lungs itself, and they may be fatal. So we need to recognize this and we need to go looking for it. I don't know. Start again, sorry. I'm sorry, it had stopped moving again. So when we look at the pulmonary symptoms and signs, we spoke about the shortness of breath, the cough, which may be persisting beyond the 8 weeks of the acute infection, chest pain, which in some persons can be debilitating, decreased exercise capacity, fatigue, which may be profound and prolonged, and the persistent hypoxia. So when we investigate these patients, what do we see? Oftentimes we request a lung function test and full lung function. And what is commonly seen is a reduced diffusion capacity. That is a reduced capacity for oxygen and carbon dioxide to cross over that membrane within the terminal bronchiole. There's also restrictive pulmonary physiology. So the lungs aren't moving as they should. So not just gaseous exchange is affected, but also the lungs aren't moving as they should. A CT scan done on someone who has COVID, and sometimes up to 6-8 weeks after the acute infection, will show abnormalities, even in patients who have had asymptomatic disease. And the more common findings are ground glass opacities, and that is just described as such because that's what it looks like when you pound the glass and scatter it all over in the lungs. But it is a marker of ongoing inflammation long after they have completed or they are out of that acute phase. Some of these ground glass opacities and the infection that may have been there with a COVID-19 pneumonia may result in fibrosis, scars within the lungs. I have a gentleman who I saw only last week. He spent 7 weeks in hospital, 6 weeks on a non-invasive ventilator. He's doing much better. He did go home on oxygen. He's now off oxygen, but he will say to you, he can't walk the distance he used to walk. And when you listen to his chest, he has what we call crackles, this just as it sounds on his chest. And it is because he has scars, and these scars are likely to be permanent. And we did speak about the clots, which we will see many times on a CTPA, that is a CT scan, a CT pulmonary angiogram. And the question is, if someone has a number of clots, what is the risk of it now affecting the heart and causing pulmonary hypertension, contributing to the severity of dyspnea or shortness of breath that these patients are having, and increasing not just their morbidity, but also mortality. So in seeing someone in the post-COVID period who is still having symptoms, what are the tests we commonly will request. Lung function tests are requested, and as I said, oftentimes what we will see is a reduction in the diffusion capacity and a restrictive picture. The CT scan, particularly if they never had a CT before, to see is there ongoing inflammation taking place on the CT that maybe we can do something about. We are less likely to do something if the CT shows really just scarring of the lung tissue, as is seen in fibrosis. For someone who is having new onset shortness of breath or worsening shortness of breath, we will request the CTPA because, as I said, we have to bear in mind that there may be clots, the risk of thromboembolism, which had formed right there within the lungs. So if you go looking at the limbs, you may not see any swollen, red, painful leg, but that is because the clots have formed right there within the chest, in situ thromboembolism. So you have to have a high index of suspicion. And then if it is that we're having someone who is having significant dyspnea, who may have scarring on the lung, who has significant thromboembolism, we need to have an idea of what is happening with that person's heart. These persons, even within the long COVID period, are at risk of having a myocarditis, and the thromboembolism and scarring that may affect the lungs can also increase pulmonary pressures, causing pulmonary hypertension. And how are we going to manage? These persons would like to return to normal life. And a lot of this is applicable to our athletes as well. So let us look at the fatigue. This is like a chronic fatigue syndrome. They just cannot get up and do what they are accustomed to doing. And we do see it in other conditions as well, although in COVID-19, it may be a protracted period. There's no evidence, no research really looking at pharmacological or non-pharmacological interventions for fatigue, but there are agents out there that can be used in some instances, although many times it may require a change in how they approach their activities of daily living. Exercise is encouraged, but should be undertaken cautiously. So the person is not said, listen, go and exercise 30, 40 minutes a day, 3 to 5 times per week. It should be cautiously undertaken, it should be monitored, and if the person develops fever, shortness of breath, severe fatigue, or muscle aches, we need to cut back. And I know Dr. Nelson will be looking at rehabilitation for athletes, and no doubt is likely to go through some of the exercises and how it should be approached. The cough, various breathing techniques have been described. And if required, we may prescribe medication, such as if there are symptoms suggestive of acid reflux, gastroesophageal reflux disease, we may want to reduce the amount of acidity, or we may want to use a pro-motility drug. We'll advise the person about their diet and their sleeping positions. And if when we've done their lung function tests, we have evidence of reversibility, then we may then prescribe an inhaler or which has a steroid in it to help to reduce lung inflammation, as well as what we call a bronchodilator to help to open up the airway. Breathlessness as well, breathing techniques, an approach or change in their activities of daily living. When do they do what type of activities? We advise them to monitor their oxygen levels. So patients need to be taught how to use the finger pulse oximetry. I had one patient call me in a panic because his oxygen levels had plummeted. When I spoke with him, he had just had a shower. It was a cold shower. And I said, okay, warm your hands up. and then repeat it. So a pulse oximeter, the finger pulse oximeter that many persons now have, is a relatively simple tool, but it is simple in the hands of persons who have been educated on how to use it. So it's not just telling a person to get a pulse oximeter, but to advise them how it is to be used. Pulmonary rehabilitation, these persons do not generally require fast track entry into a pulmonary rehab program. Persons who have had significant respiratory illness may benefit from a multidisciplinary rehabilitation based on personalized evaluation. So we have had patients at National Chest Hospital that during their admission would be seen and assessed by the physiotherapists, and post discharge, we do have a few persons who are enrolled in an ongoing physiotherapy-based exercise program to try to get them back in terms of their muscle power, their respiratory strength, and able to perform once again. Treatment includes, but is not limited to, exercise training, education, and behavioral modification. That is very important. We need to educate persons how to approach it. We need to encourage them and support them. Treatment is designed to improve the physical and psychological condition of people. And in this context of COVID-19, it does not necessarily have to be a face-to-face, but actual counseling and rehabilitation may be delivered using various virtual models. So this diagram just looks at the various systems that can be affected. And the upper system is looking at the pulmonary and cardiovascular system because they are closely intertwined. But the message here is that it is not a one person's job. It often requires interdisciplinary management to get this person through the long COVID while reassuring them, because the symptoms can last for many months. So in summary, a full clinical picture of post-COVID or long COVID, it is complex, still being unraveled, and far from being completely understood. Multidisciplinary health team is required to approach the effective management of these patients. And in other countries, you actually have long COVID clinics with an interdisciplinary team to help these persons. There needs to be increased public awareness so that we don't label persons as malingerers and time wasters and trying to benefit from the system, because if we don't address this, there may be a gloomful public health crisis if we don't truly look at this long COVID syndrome and how it is impacting the lives of many persons. You have a few studies out there that have looked at the impact of vaccines on the post-COVID syndrome. And so far, it is also believed that many persons who have received the vaccine actually have a smaller chance of having significant long COVID syndrome. In looking at our athletes in the context of the athlete and athlete health, the sporting organizations and support personnel, a key focus for them is the ability to effectively guide the athlete to a safe return to training and competition. The return to play decision-making will arise from the need to balance the impact of a period of recommended exercise restriction against the risk of having an adverse outcome from infected-related conditions, including risk of injury following any period of relative rest. This is important for all persons, all athletes, but particularly those who are at the elite international or professional level, where preparation for sporting competition is a key component of their livelihoods, a key component of athletic and career progression. So to understand long COVID, to effectively help our patients and our athletes with long COVID, these persons need understanding, they need support, they need reassurance from a team, a healthcare team, and I will dare say from our sporting managers and our coaches will be crucial component of management for our athletes. So the battle against COVID does not just end with the screening and the management of acute disease, which is a lot of what we've been hearing about the past 2 years. But now we have this post-infectious sequelae, this long COVID sequelae, which is negatively impacting our persons, including our athletes who have had either to delay their return to training and competitive sports, and for some persons actually consider dropping out of sports. So this is what we need to be mindful of. We need to look out for it. We need to advocate for our athletes. We need to advocate for our patients, because this is how we will truly win this battle. Thank you.
Thank you very much, Dr. Baker. That was certainly a very comprehensive talk. It took us through a lot of information regarding what COVID-19, SARS-CoV-2 is about, and what we should look for and what people will present with, and the fact that it requires a multidisciplinary approach to the management. We do have a couple, I see one question in the chat box from Gillian Hudson is asking. She says it's a real patient who is asthmatic with sarcoidosis, pre-COVID on BiPAP and oxygen at night, who is diabetic as well as hypertensive and 50 years old. I think she's asking what kind of prognosis would this person have? So maybe she should ask the question herself. I don't know. Gillian, if you are hearing me, can you unmute and explain what it is that you need for Dr. Baker to tell you?
Yes, I'm here. I am asking about the prognosis of this lady, because it's actually a family member who lives in the US, and I'm very gravely concerned about her health, because she was asthmatic and with sarcoidosis diagnosed a good long years before she had COVID. She had COVID late last year to early this year. She's still struggling with her breathing. She has shortness of breath sometimes at rest. She'll call me and we're talking on WhatsApp, and sometimes she starts to get short of breath. So I'm very concerned if her prognosis is very guarded or what it is exactly.
Remind me, please, when did she have COVID? How long ago?
Less than 6 months. I can't remember the exact date. I think it was in December, coming into, actually it was in January she had it. Unfortunately, her doctors over there insisted that she not take the vaccine. So both herself and her daughter, who is about 30, have had COVID, had to be hospitalized. She's now back home, but she is struggling, and I'm very concerned.
Well, I'm sorry to hear about your relative. We do recognize that persons who have underlying respiratory conditions are at increased risk of having a very protracted course. I have one such person going on for a year, hence my question of how long ago did she have COVID? What will also potentially impact her, how she does, is how well controlled she was with regards to her asthma and how active her sarcoidosis was before COVID. Because for persons whose underlying respiratory condition was controlled, those persons tend to do better with acute COVID and even post-COVID. I would say for this lady, she may have an even longer course, well, obviously, because she's gone 6 months, but she too should be seen by the team. So she has her physician, and I would dare say, depending on who she sees, she should be referred to a pulmonary specialist as part of the team. She would need to have a physiotherapist or a pulmonary or be enrolled in a pulmonary rehabilitation program, and even consider having a occupational therapist as well as maybe even a psychologist on board. We need to appreciate the life-changing impact that the long COVID can have. And what we do find is that persons sometimes want to return to their all of us would like to return to what pre-COVID was. But for a subset of persons, particularly considering the comorbidities they had before, it will take a longer approach. So for her, I still think that there is room for improvement, but we have to look at which teams, which groups of persons are involved in her care and support her. Will she return completely to pre-COVID status? That I am unclear about. I couldn't really answer that, but I still think that there may be room for improvement. As I said, I've had patients, at least one patient now going a year. And my patient who has fibrosis that I just discharged, I followed him. He's a second patient. I followed him as well for a year. But it does require a team approach, because anytime we start to think that one person knows it all is when we're going to get into trouble.
Thank you very much. Gillian, I hope that helps. Thank you very much, Dr. Baker. We're kind of running a little bit behind time. So, Dr. Baker, if you can stay with us through the whole of our session, we could probably have a couple more questions at the end, but we'd like to be able to move on. Okay, thank you very much. So I want to move now to introduce Mr. Fabian Miller is going to introduce our second speaker. Fabian, over to you.
Thank you, Dr. Atri. Good afternoon again, everyone. Rachel Irving is Jamaica and UWI first double professor of biochemistry and sports science. Her background is in clinical biochemistry, having obtained a PhD in genetic studies of diabetes in adverse pregnancy outcomes. She also has a diploma in immunohematology and previously worked at the National Public Health Laboratory for 15 years before joining the Department of Basic Medicine Science, Medical Sciences at the University of West Indies. Professor Irving has morphed the studies of genetics and immunology into research in athletics and has written 2 technical papers for World Athletics in the New Studies in Athletics Journal. She has published over 150 articles and is a reviewer and editor for 10 scientific medical journals. She has published a seminal manuscript on the genetics of West African sprinters in the Americas with the University of Edinburgh, which serves as a highly referenced paper for repatriation studies. She has also written a best-selling sports book titled Jamaican Gold, Jamaican Sprinters, and has been featured in major media in all the continents of the world. Currently, she is developing a project with Kenya through an international sports resilience funding grant that examines the effects of COVID-19 on African descendant athletes. She will be presenting to you some data from a preliminary study of SARS-CoV-2 in athletes. I must say, Prof. Irving is also an entrepreneur. She is also the technical director of LRI Medical Laboratory, one of the COVID-19 testing labs in Jamaica that is registered with Ministry of Health and Wellness in a private-public SARS-CoV-2 testing arrangement. Put your virtual hands together and let us welcome Professor Rachel Irving.
Welcome, Prof.
Hi, Prof. Irving.
Can you?
We can see the slides, but you need to put it on slideshow.
Can you hear me now?
Yes, can hear you.
Can you see the slides?
Yes, can see the slide. Need to put it on slideshow.
Right, great. Just want to know that. Okay. Go ahead. Okay. Hi, I'm going to change the topic a little bit. I'm going to look at COVID-19 in athletes, a multi-dimensional perspective. So we are looking at the progression of COVID-19. Not changing. What is going on? Give me a second. I don't know what is going on with this computer. It's frozen. Right. So I want to have some specific focus. We are looking at the impact of COVID-19 in sports setting, the immunological response of athletes, hormonal and biochemical response in athletes, and a special acronym coming out of Kenya, MIOS. It looks at reduction in oxygen saturation and reduction in oxidative phosphorylation in endurance runners. We want to look at anti-doping. How does COVID-19 affect anti-doping? We want to look at a vaccination strategy and natural immunity, because what we have found, even though some athletes got vaccinated, when we did the test for the antibodies, we didn't find any. We are going to look at some surprises. I like what my first presenter said, because many of the things that she found, we have found with our Jamaican athletes. So let's look at the pathogenesis of SARS-CoV-2. I'll not go much into this, but SARS-CoV-2, you are exposed to it. There is some sort of viral replication and likely replicates in the lung and in the gut. If you're robust, if your immune system is working, then there is immunity. You have humoral cellular immunity, and it's cauterized. The antigen from the virus is killed. If not, then you might have cytokine storm, and you have an adverse outcome. Many of the athletes didn't even know that they had COVID, but after we have done the CBC, we realized that there was some sort of reaction to the SARS-CoV-2 virus. So the effectiveness, durability of the immune response as a major implication for public health. When many of the athletes came back, the young athletes came back from Nairobi, Kenya, and they were positive. They were quarantined for 2 weeks. And, you know, I took them on wanting to do some study with them. They were like, Miss, we never had COVID. We never had COVID. The Kenyan just didn't want to see us run. We never had COVID. Even when I did the antibodies and showed them that they had COVID, they were insisting that they don't have COVID. That means sometimes there might be signs, because many of them said they were congested early in the morning and all of that, but they felt because they were in a different country, they were congested. So it means that there are many persons that might be infected, but because they are predominantly asymptomatic, it is not shown, and because of that, they can infect other persons. It also means if you're infected, you might have an immune response. And if you have to do the biological passport, you might say to other, no, I never had COVID. When they see some change in your red blood cell count, your platelet count might be high, and you insist you never had COVID, it means that they can charge you for, you know, some deviation. You can be sanctioned. What the Kenyan have found is that there is some slight mitochondrial dysfunction that cause a minor shift. And there is low, I wouldn't say low oxygen saturation, but there is a reduction in oxygen saturation, meaning most of them were like 99, and their saturation regularly became 98%. So even though they are normal, they still remain normal and they're functioning at a high level. They are not functioning at the level they are supposed to function at. We have found some shift in the oxygen saturation rate in our athletes, but because we predominantly are sprinters, it is not as, it doesn't impact us as much as it impacts those that depend on oxidative phosphorylation for ATP production. The severity of the illness depends on how robust your response is, your immune response is. And we find that the younger ones, those 14 to 18, had a robust response. Within 4 weeks, all their CBC values were back to normal. We found the athletes 27 to 35 tend to be more affected by the COVID virus. So we normally they look at COVID as it relates to children who are severely impacted, because more time children tend to go get over the infection. But what we have found is that not many studies are done on athletes who are affected and might be severely affected, but because they are physical, they are functioning at a high level, you don't see a reduction. But if you look at their performance, there might be incremental decrease in performance. And Kenya coined something, a microcytic muscle cell oxygen inflammatory process. And we are seeing this. There is a young man, he's 21. His CBC values have gone down, yet still he's not breathing properly. He's not training as much as he should. He can run a sprint, but when it comes to a 400, he gets tired. And my previous speaker spoke about that. So there is a lack of literature on how athletes respond. Previously, some studies were done, and they found that male over 26 were at higher risk of developing symptoms. And this is what we found. We found that one of our chores, he was very, very good. We had expected him to medal at the Olympics, but because he got COVID 4 months before, he ended up with a long haul COVID. And because of this, he didn't perform well. 6 months after doing his CBC, we still saw a feature of a COVID infection. Most of the athletes, the younger ones, even though their CBC values were elevated, they recovered from COVID quicker than those who were a little bit older. We also found that those who tend to be severely affected, they had heart problem, they had cytokine cascade, the C-reactive protein was high, but because they are very, very fit, they didn't end up in hospital. But you're wondering when you look at their profile, if they shouldn't have been looked at by a doctor, because even now, their profile is not what it's supposed to be. So the participants are still experiencing fatigue, headache. Some of them still have diarrhea, yet still they are still exercising. And this is why we need a disciplinary intervention where we can have many persons looking at those athletes. Should they be exercising the way they are? Are they getting as much as they should get? Had we had some intervention and look at those who were affected before the Olympics, would our male have performed, males, would they have performed better than they did? What we also found that those whose platelets were affected, they tend to continue with this COVID for a long time, even 12 months after they were infected. So what is our methodology for what we did? We did a preliminary study of a cohort of Jamaican athletes who were infected by SARS-CoV-2. Some said they didn't have any symptoms, though we see differently on the CBC count. I'm wondering if I should call this COVID-19 because basically they look all right. We are doing an international study with Kenya that we look at cross-sectional design nested in our study to see how athletes of African descent react to being infected by the SARS-CoV-2. So to rule out inflammation, because you might have your lymphocytes, your neutrophil being elevated, we did a questionnaire. Were you infected? How do you feel? I mean, did you have any muscle injury before? Because if they had muscle injury, you might have some inflammation. So we sort of put those aside. We might put them in the study, but for now, we don't want anything to, you know, probably impact what we are doing. So internationally, we were told that some of our athletes who went to Kenya, they tested positive by PCR for COVID-19. Some Kenyan, they did some testosterone study on them. For Kenyan, because they are long distance runner, they did some metabolic assays and biochemical assays. We haven't reached that stage yet. So basically what we did on our athletes, we looked at antibodies to COVID. We looked at specific parts of the antigen that will induce IgG, IgM antibodies. So we look at the enzyme, the spike protein, the membrane protein. We looked at their antibodies at acute stage, probably 2 weeks after infection. Then we looked at 1 week after infection, and we looked at 8 months after infection, which we probably call the chronic stage. We also have collected samples to see if there are biomarkers associated with the cytokine storm. So we are going to look at interleukin-6, C-reactive protein, D-dimer, neutrophil, cardiac troponin, lactate dehydrogenase, creatinine kinase, basic lactic acid, and some other proteins. What did we find? In terms of the demographic, the median age of the persons we studied was 17. We studied both male and female. Originally, we started with male, but we studied both male and female. We had 4 very young athletes, 14 to 15. Most of them were between 16 to 18 or 15 to 27. We have had a few over 31. Most of our athletes were asymptomatic. So they looked asymptomatic. The CBC said otherwise. 28% was mildly symptomatic, 71% was asymptomatic, and less than 1%, 2 out of the 28 were symptomatic. The persons who were asymptomatic, mildly symptomatic, they had some nose congestion and a little bit of fatigue, slight reduction in oxygen saturation. So they used to be at 99 to 100. They dropped down to about 98. They had a positive RT-PCR abroad, or we did it here and found that they had a positive RT-PCR. At the time of this study, when we do the antibodies, they were negative for COVID. We did some sequencing, and most of them are the Delta or the Omicron variant. All but one are detectable level of antibodies. So even though they were infected and some of them were vaccinated, we could not find antibodies to the antigen from the virus. And the blood profile was fascinating, very fascinating. And I'll just show you a few CBC. The young ones put up a robust response. For most persons at acute stage, the mean platelet volume was low, but the lymphocyte was high. Those you saw that had high lymphocyte, they tend to recover very quickly, within a month after you saw these differential count just going down. What remained of those who persist and had long haul COVID, the basophil tend to be very, very high. So this was a 14-year-old. The 18-year-old didn't react. His immune response wasn't as high as the 14-year-old. The 14-year-old antibody level, IgG, was very, very high. IgGM was very, very high. This 18-year-old had, moderate level of IgG, IgM, and this was 2 weeks after infection, just after they came back from Nairobi. We looked at somebody at 21, and this is 4 weeks after infection. And the only defining thing was the basophil. The basophil was extremely high. Most of the other parameters were back to normal, but the basophil defined whether this person really had COVID. The antibody level, we didn't see any antibody to COVID for this guy, but he had COVID because he tested positive for COVID. The female tend to be, their immune response is robust. And we see this in the lymphocyte count. And the two female that we will show you, they were asymptomatic. And as a matter of fact, they said they didn't have COVID. And we talked them down, and we did the antibodies. They weren't vaccinated. We did the antibodies and they had COVID antibodies to the spike protein. When we did the CBC, the lymphocytes were very, very high. And from our literature, we have found that high lymphocyte give you a less severe disease. And our female tend to react immediately with high lymphocytes. Basophil also defined for us, our population, whether you had COVID or not. We look at this 25-year-old, he's a male. He also had COVID. You will see that his lymphocyte is less than the 24-year-old female. So his lymphocyte wasn't as robust and his antibody levels were very, very low. This 27-year-old is one of the most fascinating person that we look at. He had COVID in March. He went to the Olympics, Olympic Games, didn't do as well, just didn't even make the final, which was surprising. In October, we took this sample and he was still reacting to this COVID virus because his platelets were very, very low. And his basophil was high, meaning there was some sort of reaction still. He said he wasn't training as much, he was tired. And my recommendation to him is you need to see your physician because there is some inflammatory process you have not gotten rid of. You're not breathing well. You need a team around you. But his coach said he was okay, so he should continue. So we just left him alone. This is our female, another female that said that she never had COVID. We did her antibody level, found that she had COVID, but what you'll find is that the lymphocyte was very, very high, meaning that the humoral and cellular response were very, very good. And this probably prevented some of the cascade in the cytokine. And we have found this in our female, those who are physically fit, that is, with no comorbidities, they tend to react immediately, and it is reflected in the high level of IgG and IgM antibodies. Another male, he got COVID, and this is, we're not expecting the red cell density width to be so high at this stage. We are not expecting it. We're not expecting it. This guy, this is 8 months after infection. It means his eosinophil is very, very high. His basophil is high, absolute as well as relative. MCH is high. It means that he's having some problem. Yet still he's saying to us, hey, I'm okay. This is 8 months after, I'm okay. Even though my profile is like this, I am okay. How do we get to them to say your training is oxygen saturation was actually about 97, and it used to be between 99 and 100. How do we get to them to say, hey, something is wrong and you need some sort of intervention? You can't continue to train like this or you'll damage your system. Nikki spoke about testosterone. We didn't do testosterone, but our collaborator in Kenya said that testosterone was low, moderately low in those who were diagnosed with COVID, those at least that were diagnosed with COVID. So how do our Jamaican athletes respond to the SARS-CoV-2 virus? Male athletes tend to have different CDC response than female. Female had more detectable IgG and the antibody tests, and they had higher lymphocytes levels. Lung function and aerobic metabolism may be implicated, and it is more implicated in those who are obese, not obese, I wouldn't say obese because the athletes are not obese. Those who are not as fit, you mean those, those who do the field events, and those who do not eat properly. So we might need some natural inflammatory, nutritional recommendation like ginger and turmeric to see if we can get down, get back the basophil to normal level. And this is just a diagram telling you about oxidative phosphorylation. And what I feel upon why these persons, when they run 400 and when they train longer, why they are having problem is that short training is anaerobic glycolysis, so you don't need oxygen. But when it goes into oxidative phosphorylation, you need oxygen. And if there is a minute reduction in oxygen, there might be mitochondrial damage, and mitochondrial damage can, cause some slight cytokine storm. The female and the younger male athletes tend to be able to shift back metabolism into glycolysis and onto oxidative phosphorylation. So there is no dysfunction because there is a robust immune response very, very early. And it, any sort of interplay is not prolonged. So homeostasis is reverted to within a month. If this does not happen, then you will have mitochondrial dysfunction, you'll have breathing problem, you will have fatigue and muscle damage. So this is just a picture of the female. They're exposed to SARS-CoV-2. Immediately, the CD4 and the CD8 are produced because they have a robust response. This is why we are seeing greater level of IgG and IgM and some IgA, depending on the kit that you use. We're seeing greater level because immediately there is this response. And because of this, the immunological markers, the cytokine, the creatinine kinase are not elevated. We're not seeing that in the older male athletes, those athletes that are between 27 and 35. Their response is not as robust as the female of the very same age and the young male, 14 to 18 years. So what have we found? The younger athletes tend to be more asymptomatic. They have a better cellular immunity. They have a better response, and they recover faster. Young athletes who have not recover well tend to have decreased oxygen saturation, and we have seen this. We have done it over and over for this young man who, you know, he used to train, do some background 400-meter training. He can't anymore. So he'll do 100-meter stop and all of that. The coach need to probably look at his lung function, look at his muscle function to see if he has any slight damage that can be, you know, aggravated. Long-haul COVID in athletes tend to be associated with elevated basophil and dysfunction in the erythropoietic pathway. You have prolonged low mean platelet volume, and there is some disturbance in the red blood cell formation. So we need to look at long-haul COVID in athletes, because as Doc said before, they may get clots. If we are going to have problem with coagulation and platelets, they might get clot. And if they are not breathing properly, if there is decremental decrease in the oxygen saturation, you're pointing them to danger. If they continue, they might have myocarditis if they continue to exercise at that pace without some intervention. And performance seemed to be impacted in all athletes greater than 25 who have had COVID, low MPV and low neutrophil count. They have had symptomatic COVID. It means that we could, had we been proactive, we could have done a prevalence rate of COVID in our athletes and sort of try and get, you know, reduce the inflammatory process. And probably we would have gotten more medals, or we would have done better at the last Olympics. Stay safe. Stop sharing. And these are my references.
Thank you very much, Prof. Irving, for this talk. Some of it might be a little bit over our heads, but I think we can appreciate the fact that the younger athletes and the female athletes definitely seem to have a more robust effect with respect to the immune response. And from your studies, it shows that these athletes were better able to get back out and do better in the training as against the older male athletes who didn't seem to do as well, even although many of them did say that they didn't have any symptoms of COVID and therefore they didn't have any COVID, but your tests prove that they actually did have. There is a question in the chat box. I'm hoping that I can put this to you correctly. The question is, did any other viral studies for persons with long-term laboratory derangement? Were there any other viral studies in persons with long-term laboratory derangements with respect, saying things like dengue, because this can also cause a low platelet count, and that viruses can cause an elevation, can cause elevated or deranged lymphocyte counts, and any other kind of parasitic infection can also cause eosinophil levels. So I think the person is asking if there were any other possible reasons why these individuals may have had the laboratory results that you found, and if dengue or any other sort of parasitic infection was considered.
I think Prof. Irving lost connection, Dr.
Oh, she lost. Okay.
All right, so we will hold that until she returns. And if any other question, they could post in the chat, and we'll explore later on.
Okay. Do we want to move on then? Do we move on to our next speaker?
Yes. Yes.
Okay. All right. So coming up for our third and final speaker for the afternoon, I am going to ask Justine Edwards, if Justine would be kind enough to introduce our speaker, Miss Gail Nelson. So Justine, will you go ahead for me, please? I'm not sure.
Hi, good evening, everyone. It is indeed a pleasure to introduce to you our final speaker for this evening. I will say of our esteemed guest speaker that she is a consultant physiotherapist and clinical cardiothoracic specialist with 30+ years of experience in the profession. Currently a lecturer, researcher, and administrator at the School of Physical Therapy at the University of the West Indies, Mona. She has either written or co-written several publications covering different subjects in the field. Her professional advocacy begins with a passion for excellence in practice and progresses with knowledge sharing and empowerment of others. A graduate of the University of the West Indies and the University of Melbourne, Australia, she is currently a doctoral candidate in the Department of Medicine, UWI Mona. Our guest speaker is a member of the Jamaica Physiotherapy Association and the Jamaica Association of Sports Medicine, and a violist in the Jamaica Philharmonic Orchestra and the UWI Classical and Jazz Ensemble. With the quiet expectation that she will also thrill us with a rendition from her musical repertoire, I would like to invite our guest speaker, Miss Gail Nelson, to address us. Welcome, Miss Nelson.
Thank you, Dr. Edwards, and there will be no renditions today.
No, doctor.
Thank you very much for the warm welcome. No, thank you for aging me so much, 30 years. And I would want to thank the Jamaica Association for Sports Medicine, for asking me to do this, and also for bringing the conversation about rehabilitation post-COVID for athletes into the public space. Okay, let's begin. So just to highlight that the timing of this discussion and this presentation today is actually quite critical, I just want to show very quickly what the COVID-19 burden looks like in terms of daily new confirmed cases over time. And you notice the several surges that we have had. We started, let me just get a pointer here. We started, COVID-19 came on the scene, as Dr. Baker said, in December 2019 in Wuhan. And the first case was recorded in Jamaica in March of 2020. And we noticed since then, Jamaica is here in the green, and the United Kingdom is this kind of fuchsia color here, the largest peak, and Europe a kind of teal, a little below it, and the US in between. And what I want to point out is that after surges in these three territories, you see Jamaica surges a little bit afterwards, and that is continuing right up until now. So although we have discarded the Disaster Risk Management Act and we have opened up considerably, COVID-19 is still for quite a while. And we can expect a surge following the same pattern with what has happened in earlier this year. And just now, we can expect another little surge to occur in Jamaica. What we are observing is that persons may not be becoming as ill, and the mortality rate seems to be falling, but the infection rates wax and wane. I seem to be having the same problem as everybody. Let me get a pointer. Oh, there we go. Now, globally, we have recovering from COVID-19, 414 million cases. And in Jamaica, we have just over 80,000 cases. And with the prevalence rates cited by WHO of long COVID being 1 in 5 persons having persisting symptoms or of some kind of mid and long-term effects of COVID, I think we're looking at about maybe 16,000 people potentially with long-haul COVID or post-COVID conditions in Jamaica. And these numbers would be an underestimate of what really is out there, because this is only of confirmed cases, and we know case counts are higher than what we have confirmed. So it is critical and timely for us to be looking at how we get persons with post-COVID conditions back to their optimal level of functioning. And a subset of those persons would be our athletes, whether elite, professional, or even our high schoolers or young persons who look for scholarships through Gibson and Champs each year. Their performance, in other words, is an important part of their performance now is an important part of their career trajectory. So I'm going to try to minimize the repetition. Dr. Baker had
just a second. Is it possible to turn up your mic a bit? Someone is saying that they're not hearing you. Can you turn up your?
Tell me if this is any better.
Well, I'm hearing you clearly, very clear. So.
Okay, all right.
What's
So maybe they can log out and log back in to see if it will.
Thank you.
Thank you. So this is just a reminder of what post-COVID is. It's an illness that occurs in persons with a history of probable or confirmed SARS-CoV-2 infection. Usually that comes up within 3 months from the onset of COVID-19, and with symptoms and effects that can last at least 2 months. In the literature, there is no statute of limitations. There's no upper limit given. There's no maximum time limit given beyond which a new symptom onset can occur, not at this stage. And I'm saying this deliberately to bring out later on that monitoring during exercise, during return to sport is critical, because of there's so much that we don't know about post-COVID syndrome. The symptoms and effects of post-COVID-19 condition cannot be explained by an alternative diagnosis. It is a diagnosis of exclusion. And common symptoms include the fatigue, as she said, the shortness of breath, the cognitive dysfunction, and there are others, other respiratory manifestations and cardiac manifestations. And generally they limit exercise capacity. Symptoms may be new onset following the initial recovery from an acute COVID-19 episode, or they can persist from the initial illness, and it can, the symptom, the intensity of the symptoms or severity of the symptoms, beg your pardon, can fluctuate and relapse over time. This study, I'm sure we can move the tab at the top, but this study I wanted to mention because it looks at it aims to estimate the persisting disease after severe COVID-19 disease. And the patients with COVID-19 were followed up for 140 days post-discharge from hospital. So these were following up patients admitted to hospital for management of SARS-CoV-2 infection. And the main outcome measures used were compared with matched controls from the general population. That's what I thought was so interesting about it that I want to include. They found approximately 47,000 individuals discharged from hospital before 31st of August 2020 discharged alive, they said, and followed them up for 140 days post-discharge. And they matched these 47,000 individuals with controls in the National Health Service, studies out of the UK. They matched them with controls, they matched them for age, and they matched them for pre-existing conditions. They just could not have, the controls did not have COVID, but everything else was matched: age, sex, comorbidities, okay? And they found that one third of the individuals who were discharged from hospital after acute COVID-19 were readmitted. And when they compared to controls, and also the rates of respiratory disease and cardiometabolic disease were higher in the post-COVID patients than it was in the matched controls. And also showed that the disparity in the post-COVID conditions, the incidence of the post-COVID conditions was much wider amongst the younger persons, people below 70, than they were people above 70. And the conclusion was that individuals discharged from hospital after COVID-19 had increased rates of multi-organ dysfunction compared with the expected risk in the general population. And the increase in risk was not confined to the elderly and was not uniform across ethnicities. And the question you might ask is, and I had asked, when I thought about our athletes who were considered to be lower risk for severe SARS-CoV-2 infection, is the look different? Is the look different in terms of the incidence rate of post-COVID condition for persons who are not hospitalized, meaning it wasn't critical enough for them to be taken to hospital? This was a smaller study that the CDC did. 3,000 persons participated, and of the 3,000, 2/3 were found to have visit about, let me see, 2/3 had at least one outpatient visit for a new diagnosis of a condition about 1 to 6 months after diagnosis. So it would appear, it's difficult to compare studies, I know, because the methodologies were very different, but it is instructive to see that the non-hospitalized face similar risks of developing post-COVID syndrome as the hospitalized. Most post-COVID patients were seen for family or geriatric purposes, mental health consultations, dermatology, cardiology, gastrointestinal, neurology, and pulmonology. One thing I wanted to point out in this population, the non-hospitalized, according to this study, the symptoms that were persisting from COVID-19 tend to be the pain in the throat and chest, shortness of breath, headache, malaise, cough, sleep disorders. But what I found intriguing was that their new diagnoses were not predominantly respiratory or cardiometabolic. Theirs were musculoskeletal, and there was some change in body composition. Also, they found there were new diagnoses of obesity post-COVID. So what are the implications of this? It's really that pre-participation screening for our athletes to return safely to sport is crucial. Now, this was always crucial, and we have had several debates and discussions about what must go in the pre-participation screening workup over the years, especially as we have seen, it appears, increasing incidences of sudden cardiac death in our even young athletes. But I want to point out that we have to go back to that table and look at investing in pre-participation screening for our high school athletes in particular. And I'm picking on the high school athletes and the recreational masters athletes because the elite athletes have the money and the sponsorship to do a thorough workup before they resume sports, whereas the high school track teams and so on, they have less resources available for that and sometimes are, I think, unfairly exposed to risk. So athletes with probable or confirmed SARS-CoV-2 infection should be carefully medically screened prior to return to sport-specific training, whether they are symptomatic or asymptomatic. And this is especially important, as I said, for our masters athletes. Now that pre-participation screening must collect from the athlete any symptom history. It's important that the athletes in particular have a higher level of their body awareness than in the general population. They knew how they felt before with exercise participation, and they know the differences post-COVID. So it's important to take that history from them because it's actually very helpful in monitoring how the exercise prescription is progressed, right, when it comes to training. The medical evaluation must be done to identify the impact of COVID-19 on the athlete, as well as to establish the baseline fitness. I think because athletes are preparing for movement, an athlete who is very talented, who wants to go pro, it's very difficult to say, take your time or don't do this. It is very frustrating for them to hear you can't do this anymore without telling them what they can do and how. And I think the key to doing this safely is in this workup. So exercise, the evaluation must include an exercise stress test of some sort for the simple reason that when you're pushing your athletes to higher and higher intensities in the exercise prescription, there is what I call occult cardiac or respiratory or other types of condition that you will miss at rest that will become unmasked at higher exercise intensities. So I think it is crucial at the evaluation stage to administer your ECG stress tests or stress echoes. I always felt it was relevant and protective for measure for our athletes, but I think particularly in athletes who are post-COVID with higher risks of cardiometabolic disease and respiratory disease, that they must be screened properly. We have gotten so much from them in branding for this country. We need to invest in their care. The basis, the reason we're doing the testing is not to restrict participation so much as it is to help them to safely participate in sports. So the treatment based on the results of the evaluation should be developed with the particular disease characteristics of post-COVID that they are showing, right? And this is in order to improve their long-term health. Now, it's not a lot of information out there about how this medical should be done for our athletes, but the Northern Ireland Sports Institute published these guidelines last year, and they had what you call a restratification. So the tests would be applied in the medical evaluation based on the COVID-19 risk assessment. So everyone needs a focused medical history, clearly, and that's crucial. Persons with, and everybody needs a thorough physical examination. I'm going to speak more about that later in terms of the physical examination being specific to the demands of the sport on the athlete. You have to test the systems that are going to be used by the athlete in performing this sport. Persons with a history of mild illness, they recommend should have a 12-lead ECG, or persons with new onset cardiovascular symptoms. Persons with moderate to severe illnesses or COVID-19 infection and documented multi-organ injury must have a 12-lead ECG. I would wager a stress echo would not be a waste in this population either. Would provide information, certainly tell us how hard we can push in exercise training. And the blood and other test recommendations are there. For persons with multi-organ dysfunction or any multi-organ injury, the liver function test, C-reactive proteins are, measure of C-reactive protein is recommended by this sporting body. And everyone, if you look across the board, everyone must have a comprehensive evaluation prior to return to sport with a sports physician, or sports, for the multi-organ folks, sports cardiologist. This algorithm by the same Northern Ireland Sports Institute is to show, well, after you have done the medical assessment, after you have restratified, after you have done your medical assessment, then what? And it is recommending for persons who are asymptomatic with a negative test, they can go right back to full training. They have clearance of full training according to the guidelines. Persons who had antigen test positive or antibody test positive are recommended that they go through a rest period, at least 7 days post-test, and they progress through some kind of gradual return to training protocol, daily monitoring, and of course the monitoring is going to be directly related to any deficiencies identified in the evaluation. They should have a negative, well, not should, consider getting a negative PCR prior to return to sport. And persons who are symptomatic, they are grouped based on how long the symptoms persist post-diagnosis. And those who are persisting beyond 14 days should undergo a full, well, everybody actually should undergo a full medical assessment. And we had discussed in the previous slide the details for the medical assessment. What I like about this is that everybody must undergo, as part of their workup, the recommendation here, a graded submaximal exercise test. Okay, and in that test, you're looking for symptoms of excessive fatigue, dyspnea, chest pain, dizziness, palpitations, myalgia. This is a controlled setting where the right personnel are there. If anything, you can spot what is happening as the test progresses, so you can make any changes right away or administer any interventions right away. Okay, so they are safe tests, and they protect the athlete later on from avoidable, I think, accidents as a result of progressing exercise too rapidly. You watch for heart rate rise during exercise, and also return to baseline resting levels post-recovery. As Dr. Baker had pointed out, one master's athlete, I think she would qualify as master's athlete, Zola Budd, noticed a longer time to return to baseline levels post-exercise compared to before COVID. The rating of perceived exertion is a fantastic way. The Borg scale is a 6 to 20 scale in particular, is a fantastic way to collect objectively, if you will, the subjective feel of the athlete in response to the exercise intensity level. Okay. So based on any issues identified with this test, you can decide whether there needs to be further investigation to unearth the causes of any deficiencies highlighted, or if all is well, they can go to full training. But the name of the game here is safety safety first. I don't know how to go back. I've gone too far. Let me see. Yeah, I do know. Okay. Once medically cleared, the athlete should undergo once medically cleared, they undergo appropriate exercise testing. So there is medical exercise testing and there is exercise testing that is that we ought to be doing based on the type of exercise training and the type of sport to which the athlete is returning. In other words, I'm saying the other exercise tests must be tailored to the functions required for this sport. Is it a power sport? You have to do power test. Is it aerobic? You have to do aerobic. Is balance required? You do your dynamic and your static balance tests. Agility testing agility is required for the sport. You do agility testing. Flexibility is always good across the board, I believe, when you're doing muscular conditioning test, and strength and muscular endurance. And to recognize that there are tests, the exercise or sports medicine professional must recognize that there are tests that are fit for the purpose of for which you are testing the athlete, and we should select the appropriate test. Otherwise, we will miss information and we will be less able to construct a safe and effective exercise prescription. Remember, principles of exercise physiology: overload and specificity. You cannot get in order to get the desired adaptation in the system, that particular system has to get an overload. No matter how small it is, there has to be an overload. So, and the only way to quantify safe limitations for that load is through exercise testing prior to prescription, okay? And monitoring thereafter. And specificity, the system that you want the adaptations in is the system that you have to train. Careful monitoring, and I cannot overemphasize this, careful monitoring of exercise responses should be done during testing as well as, don't get there yet, but in training. And this should be guided by any physiological deficiencies or abnormalities that were identified in the medical evaluation. Safety matters a lot, and each member of the sports medicine team has a role to play in ensuring safe resumption of sport for I call it the coach-athlete synergy, because one does not work without the other, and we know this, right? So teamwork makes the dream work. All of us have to become au fait with what to expect from athletes who have symptoms persisting that can be described as post-COVID or long COVID. And we must also recognize that because we have not yet established a time limitation for the onset of new symptoms, that we need to be consistently monitoring, keeping in mind what Dr. Baker had explained, what Professor Irving had explained about the nature of the insult SARS-CoV-2 infection causes. So factors which affect the level at which the athlete can resume training, it's really not different from anybody who has had any other type of illness. The pre-COVID level of athletic activity is important. The intensity and type of training to which they are going to be, in which they are going to be engaged. Their diet and nutrition habits maintained during quarantine. That is going to affect energy expenditure, desired body composition changes. Certainly, let us not forget diet and nutrition underlie the effectiveness of any exercise program we can give these athletes. We also have to consider the severity of COVID-19 symptoms the athlete experienced, and the presence of other factors such as altered sleep patterns, uncertainty of returning to training, and feelings of depression and anxiety. I just wish to highlight here, I have here severity of COVID-19 symptoms the athlete experienced, but I've had two, well, one was a post-COVID, not an athlete, but this person went to the gym 6 days per week for several years. And he was 32 years old. At the time he came to see me, he was about 6 months worth of deconditioning, and yet I was still able to see very good muscle definition. So just to tell you, and he came because at 1 month post-COVID, he felt palpitation. He had gone back to the gym because he felt he could, developed palpitations, and went to his cardiologist and discovered that he had cardiomyopathy with a ejection fraction of 30%, meaning his heart function had dropped to 30% of what it's supposed to be putting out. And this is an otherwise healthy young man. No premorbidities, was not hospitalized for COVID-19. And this had another young lady, well, tested negative for COVID, but had a post-viral myocarditis. Tested negative for COVID, yes, but had a post-viral myocarditis, and who was troponin positive, had cardiac enzymes. Her cardiologist sent her after she produced a negative troponins consistently, and this particular patient had to go through training to pass a physical test, an exercise test to keep her job. So I'm just saying that, and these were two youngsters. One was 42, 42 youngsters, and the other was 32. And both had neither of them had any severe symptoms of a viral illness. So it just goes to show that the severity of the involvement of post-COVID really in some instances bear no relationship to the severity of their symptoms. And that's all the more reason why we need to be safe. So we use our screening test results to manage the risks for any injury or event. Okay, so monitoring is key, and your monitoring is going to be dependent on the deficiencies identified. As Dr. Baker had identified, it could be if there is a lot of scarring of the lungs, there's going to be fibrosis. You can expect, or I shouldn't say expect, let me say, look out for any desaturation with oxygen desaturation with exercise. May not be there, but it can be, and it's not that they can't exercise. It's just that you'd have to put other measures in place in order to get the desired exercise intensity. That is enough to trigger the desirable adaptations. Same thing, if there's any cardiac deficit, you're going to have to monitor for that. Monitor for arrhythmias. Sometimes it doesn't really take a lot. They don't have to be exercising with ECGs. Really, you can just make sure that you either auscultate or palpate at the pulse rather than just use the pulse ox, which will not necessarily point out any irregularity of rhythm. You can palpate the pulse to see if there's any change compared in the volume and the rhythm of the pulse compared to when they were at rest. Certainly make sure that the exertion level is within the range that you want it using the Borg rating of perceived exertion scale. So I think athletes with long COVID who are returning to sport should be individually supervised when they are just starting exercise until you see that it is safe, and you can diminish the exercise supervision as time passes. And a key part of diminishing the exercise supervision safely is teaching the athlete how to spot an adverse, how do I say this? How to spot an adverse event before it happens, right? Teach them what to look out for to know they must modify the exercise program or stop it or terminate, okay? So to determine the start intensity, these persons are coming from a COVID infection. The start intensity is not going to be the same as the desired workload for the training effect to occur. It's going to take a little while to work up to that. And it's not guesswork we use to get there. It is calculated based on the exercise test results. And we spoke about principles of overload and specificity before. Safe design of the exercise session means that we give our athletes a slow warm-up time. If they could warm up in 5-10 minutes before, give them 20. Okay, and of course, the nature of warm-up, you're slowly progressing the intensity during the warm-up. Remember, the purpose of warm-up is for the heart, the cardiovascular and respiratory systems to catch up with what the musculoskeletal system is doing. Very quick. Once it's said, do the brain tells the muscles to high knees. They can't do the high knees straight away, or they can go up the stairs straight away. It takes a little while for the heart rate to adjust, for the endothelial responsiveness to trip in, right? So all up to recruit, and then to recruit, fully recruit your airways so that you're having optimal ventilation. These things take time to occur, and the warm-up is to allow for that safely. They always should have a warm-up, but I think more so when function is compromised in the presence of an illness is very important. Take a longer time to get to steady state. Take a longer time to attain the effective training load. And for cool down, opt for an active cool down rather than a passive one, so that venous return is to the heart is maintained, and there is no increased myocardial workload because blood is pooling in the lower extremities. Avoid the higher intensity of training until these symptoms, if they are persisting, are resolved. Any shortness of breath, lightheadedness, muscle aches, weakness, fatigue. We have to respect the limitations of the illness and work within, safely work within those limitations, even while we are giving an overload. Okay. In terms of the exercise prescription, how often will we want the athlete to train? How do we want to schedule the recovery days? What do we want them to be doing on the recovery days? We have to consider all of this with our post-COVID athletes. For how long will the athlete train in a particular session? How hard will he or she train? And what mode, exercise modes will the athlete use to train? And the decisions that we make about each of these, this is a fit principle, the decision that we make about each of these will depend on what we, so how often will depend on how long. How hard will depend on how long and how often. What mode will depend on how hard. Okay. So the one component, the level of one component will depend on the other. It will also depend on the type of post-COVID condition that is there, and it will also depend on the athlete's baseline level of fitness. So this is a recommendation of the same institute that I had, Northern Ireland Sports Institute, for graduated return to sport progression for athletes with long COVID. And they are saying that at this stage one, the pre-participation period, it really ought to be, they're staging the pre-participation period 10 days post-symptom onset or 7 days post-symptom, okay, post-symptom cessation. And they're saying that should be rest. And of course, that is going to be supported by good nutrition. And let's be clear, when we say rest in particular for athletes, we're talking about relative rest, not cessation from full cessation from activity. You know, we need to keep some large muscle group work going. So it's really about just engaging in functional activities during the course of the day during this rest period. And then at stage 2, they are recommending exercise duration of a little less than 15 minutes of light activity, but large muscle group work. As we see there, the modes are walking, light jogging, swimming, stationary. For all of our athletes, no matter what type of sport they engage in, they all will need a baseline endurance, aerobic endurance level in order to perform well, even if it's a power sport. Okay, and this we need to maintain that or get that back even before they go to sport-specific training. Okay, and as time passes in the recovery period, the exercise duration increases, and throughout the entire process, the symptoms are being monitored. Just get my pointer. Symptoms are being monitored. You're looking for fatigue, and I like the use of standardized outcome measures for these. So there's a fatigue severity scale. There are different types of fatigue scales you can use just so that you can compare, you can look at properly assess progress over time. You can use the Borg dyspnea scale for measuring shortness of breath. You can use angina scales for measuring any chest discomfort. Dizziness, well, that's either present or absent. Palpitations, any muscle pain, any persisting muscle pain. And the difficulty here with myalgia, as you see, is a prominent part or consistent part of long COVID, is to tease out the myalgia of long COVID from the myalgia of delayed onset muscle soreness. And I would say a standard rule would be 24 hours post engagement in exercise, the athlete should not have an increase, a persisting increase in muscle soreness. If he or she does, then it means the exercise was too intense and should be, the intensity should be decreased. We watch heart rate at rest, how much it goes up to for exercise, how much it comes down to for recovery. Okay. Let's get rid of them. When do we adjust or terminate? And I'm almost at the end now. When do we modify or terminate exercise training? If any of these things happen, right? If there is any chest discomfort with any exercise at all that we have, even if we calculated it textbook correct based on the exercise tests that we administered, and the athlete develops any of these, we have to modify or terminate, depending on how the patient is presenting. So if there's any chest pain not alleviated by rest or with decreased in exercise intensity, you have to terminate the exercise session. If there's any shortness of breath in excess of 36 breaths per minute, if the rating of perceived exertion is inappropriately reflected to you as heavy, that's about 15 out of the 6 to 20 RPE scale. If the post-exercise recovery time is exceeding 5 minutes, that doesn't mean you have to terminate exercise training. That means you need to modify. Okay, it means it needs to modify. It should be 5 minutes or less. Okay, otherwise it meant it was too intense. If the oxygen saturation is dropping by more than 4%, or well, I say at least 4%, because there are some athletes who will demonstrate exercise-induced arterial hypoxemia, and that is quantified as 4%. And their performance is actually fine. Nothing is wrong. It's just that they show, some athletes tend to show that. But certainly in post-COVID, if it's dropping by 4 or more, then you have to adjust the exercise training setting as well as the intensity. Okay. Might have to give supplemental oxygen during exercise. It has no carryover effect at all, but it will allow you to reach sufficient training intensities without, that will give you a beneficial adaptations without causing any harm. If there's any falling blood pressure during exercise by more than 10 millimeters mercury, if the patient feels tired and weak up to 24 hours post-exercise, then it was too much. Right? Any complaints of feeling clammy, dizzy, nauseous, development or increase of pulmonary rales, prevalence or of significant arrhythmia. Arrhythmia is significant, sorry, when, based on the type of arrhythmia and the symptoms that the patient presents with the time of arrhythmia, and signs of failing cerebral perfusion. Important points to note: think safety first. right? Testing is important. The long COVID, a lot of unknowns about long COVID. The way to maintain control of a safe environment for our athletes is to do a thorough evaluation and monitor them throughout the course of training. Post-COVID conditions can cover multiple organ systems, so we must be careful to listen to our athletes and do not be dismissive of any complaints. Okay, it's better to err on the side of caution. Okay, progress exercise intensity carefully. Cardiac and respiratory symptoms can go undetected until higher exercise intensities are reached. Always keep in mind the athlete's reported symptom history, because this is what tells you what to monitor for in terms of distress during the exercise. And also keep in mind any new exercise limitations that they would have reported post-COVID. We have to be patient with our athletes. Post-COVID symptoms can persist for 6 months. Dr. Baker gave the instance of the athlete whose symptoms persisted beyond 10 months or more. Okay, a lot of unknowns there. We need to increase workload progressively for exercise to be effective, but how we do that must be guided by what our patients and athletes reflect to us in their response. Okay. Thank you. Are there any questions?
Thank you very much, Gail. Well done. I'm sure that we all have a better idea of how to progress the patients or athletes, what to look forward for, and the importance of the sports evaluation, the pre-participation evaluation, the importance of that. So I'm going to ask at this point for all our speakers, Dr. Baker, yourself, Dr. Irving, who had some technical difficulties and we didn't get an opportunity to feed her the questions that were being asked, to give us a couple of minutes. There are some questions, so all of you will receive questions from the audience in a couple of minutes. So I'm going to start, if I may start with Dr. Irving first. Dr. Irving, are you there?
Yes, I am.
Okay, Mr. Miller Fabian, I think you are best to ask your question. It was a little difficult for me to understand. So I'd ask you please to go ahead and ask Dr. Irving your question.
All right, hi, Prof.
Hi, how are you?
Right, so this question is actually coming from YouTube. Dr. Jones asked me to ask you if there is any other viral studies for the person with long-term laboratory rearrangements, if that was done.
Well, to be truthful, there's a global funded program to look at long COVID in athletes. I'm not sure at this stage because it would take me to Kenya. So I'm trying to train some postgrad who would take that on because they're looking at a 5 years study. And I'm not sure that I want to be so involved at this stage. I was supposed to have been in Kenya at the World Youth Championship to test those who tested positive there. But I was afraid to travel with COVID. So when I'm looking, I'll start the process and pass it on. I'll start the process and make the connection and pass it on because they're looking at a whole lot of parameters in athletes who suffered from COVID.
Okay. Another question was there any test done when the females were not menstruating? As we know, menstrual cycle can cause elevated temperatures during ovulation and may stimulate alterations in white cell counts. And I suspect that Dr. Jones is talking about the different markers where the white cells are concerned.
What we have done, we have stored the serum to do further testing. We did some initial CBC. We looked at the markers for COVID in that you're supposed to have IgG IgM antibodies. If you're not vaccinated, then you know it came from, it was produced because of the COVID antigen. If you're vaccinated, you're not sure because it might have been produced by the COVID antigen or as a stimulation, the COVID antigen stimulating those antibodies, or it might be antibodies to the vaccine. So what we are doing is storing those samples because COVID is so dynamic and we don't know much about COVID. So we are storing those samples because China is now developing an antibody that differentiates between an antibody test that differentiate between the vaccine antibodies and the antibodies from natural immunity. That is the antibodies if you were exposed to COVID. So we are storing samples at this stage to do further testing.
Okay, very interesting. Prof, also, I remember you said that the Kenyans did some hormonal testing regarding testosterone. Was there any, did you see any relationship between certain white cell counts and testosterone in terms of the level?
No, I don't know, because what the Kenyan are doing is ensuring that they have a biological profile of their athlete, just in case WADA comes to say, hey, your testosterone was, tampered with. They have a profile because no profile is being done at this stage. So they have a profile that they can refer to. So they have been proactive, and it's, I think we should have done that. We need to have a profile of these guys. So when they're tested again for the biological passport, we have a comparison, because we can't defend anything that happened. We can't say it's because of COVID when there is no COVID antibodies.
Right.
And the athlete denies that he ever or she ever had COVID. So I think they're proactive, but Kenya was just awarded a whole lot of money to develop therapeutic for COVID and to develop vaccine for COVID and all of that. So they are into a whole lot of COVID testing in terms of protecting their population at this stage.
Okay, thank you, Prof.
One other question, Prof. We're in a situation whereby a coach chooses to disregard the information that you have, whereby to say that athletes who are asymptomatic can have the long COVID effects, because you are showing this to be a possibility. What, if anything, can we do to safeguard the athlete who may be the coach may be pushing to train or trying to get more out of them, not believing that they are actually having any kind of effect from COVID because they were asymptomatic, but yet still your research would have shown that even although they're asymptomatic, the factors are still present in their system.
It is hard because I had two examples. We had a 14-year-old and a 15-year-old that were positive in Kenya. They came, we did the test, and their parent or themselves didn't accept that they had COVID, even though they had the antibodies, even though the white cell count was AY, even though there was some deviation in erythropoiesis. They still didn't believe us. What do you do? It's voluntary. We are doing research. What do you do in that case? There was clearly some inflammatory processes, but they themselves didn't believe because they were able to run and perform in Kenya. And the mother said, listen, if my son was able to run and got a silver medal, I think, in the relays, you cannot tell me that he had COVID. The facts were there.
Well, it would seem that I guess this is a matter of just moving slowly, day by day. And if the athletes develop symptoms that the parents and the coach can actually see that they're having a problem, maybe they'll better understand. And definitely following on what Ms. Nelson has presented to us, it shows the fact that we really need to progress slowly. So we can only try to educate, and hope that some of it will sink in.
Okay.
Thank you. I'm not sure if there are any other questions for Dr. Baker or Ms. Nelson. People could probably just put up their hands if they have a question.
Well, I have one question, maybe two, from Ms. Nelson. Ms. Nelson, you might have said it, you probably had said it, but in terms of the types of athletes, yes, I do believe you mentioned something about the strength power athletes, but can you just remind me, your strength power athletes, or throwers, to some extent, or sprinters, well, we recently had bobsled. What are your recommendations with those kinds of athletes? How do we approach their return to sport? Well, their exercise testing and their return to sport. How would you recommend, or what would you recommend in that case?
Not different from any other, that you test the system that they're going to use for the sport. So for those, plyometric testing would be important for your power athletes. And as I still feel that even though those events you mentioned are predominantly power, that they do need a certain basic aerobic. Yes, and it should be tested for detection. Well, this time it's not just for preparation to carve out an exercise prescription, but to discover or to unearth any occult cardiac or respiratory issue that might be limiting exercise participation. So I think everybody should have that. That's my feeling. Right. I smile because I know those tests are costly in Jamaica, but I do feel that for what athletics has done for Jamaica, a commensurate investment should be made in the well-being of our medical well-being of our athletes. Agreed. So, but for crafting the exercise prescription, Dr. Brown, I do believe that the testing has to be, the energy system has to be tested, right? So plyometric training, anaerobic, looking at, make sure you understand where the anaerobic threshold is, that kind of stuff.
Right. Well, do you think it may be harder to maybe detect those occult symptoms in those kinds of athletes? Seeing that some of them, say the throwers, I do know they do cardio training to some extent, but they tend to do less. Do you think it's something that we could more easily miss, so to speak?
I'm not sure. Why would you say that? Because I'm not following why it would be easily missed in that group.
Well, all right. Meaning, for example, well, you did mention that, it's when sometimes the symptoms really come up when the athletes are really pushed in terms of their maximum capacity and so on. So I was wondering if maybe in our power athletes, if that's something that we have to be especially cautious of, not to overlook that aspect.
Got you. And well, what you're asking underlines the importance of doing the screen.
Right. Yes, definitely.
Yeah.
Right. Okay. Any other questions? Any questions on the YouTube, Mr. Miller?
No other questions.
Well, once again, thank you. A big thank you on behalf of the Sports Medicine Association to our presenters, Dr. Terry Baker, Professor Rachel Irving, and Gail Nelson. Thank you. All the information that you have shared today is invaluable. It's really a good eye-opener for us to ensure that as healthcare professionals that we really stop and think about COVID-19, the impact it has on our athletes, and what we need to do as healthcare professionals, as sports coaches, fitness instructors, whoever has logged into our session today, physical therapists, what we need to do in order to provide our athletes with a safe environment to craft their skills and to ensure that they get the best out of their performance, the best that they can for their performance, but doing so safely. The importance of the pre-participation examination. I was just so pleased that Gail had mentioned it, because when Dr. Baker was talking, that was the one thing that just kept coming over and over in my head. And then when Gail mentioned it, I said, oh good, somebody is bringing that up, because we realize just how important the pre-participation evaluation is for athletes before they start their program, and now even more so that we have the long-term effects, the long COVID effects that can happen with our athletes. Assessment, as physical therapists, as coaches, fitness people, we need to ensure that we train our athletes properly, we follow the instructions or the guidelines that have been provided by Ms. Nelson, which I think are very good guidelines to follow. So again, thank you very much for being here. Thank everybody for joining in. We had a full house. Our Zoom link was full. We had 100 people, and we had a few people. We had about 10 or so people on YouTube.
19 on YouTube. 19
on YouTube. So really great, great following today, and all has gone very well, and we really appreciate everybody's tuning in. So with nothing else, if I'll put it back to our co-chairman. So Fabian, you can take over to bring our session to an end.
Yes, Joe, thank you very much. But if everyone will permit me, I'd just like to give maybe one final special thank you to our very own Dr. Joan Matre, who you're seeing highlighted right there. So Dr. Matre, she's our immediate previous education committee chairperson, and she actually chaired the education committee of the JSM for, I'm gathering, it's at least 6 years. So we're talking about three different executive boards, thereabouts. Right. Anyway, so we really want to thank you for your stewardship previously and even now. You're still giving us guidance, recommendations, and so on. I know you're trying to wean us off. I guess we're kind of weaning off slowly.
Off the skirt tail.
there you go. Right, but we really want to thank you for your guidance and so on, for your leadership previously, and of course your continued guidance and your continued activity in the education committee. We have a special token that we're going to have sent to you at some point, probably take a picture or something like that, to share with the association. But again, thank you very much, Joan, for your leadership to this point. Okay. So everyone, I guess, yes, with nothing further, I just want to thank everyone again for attending. Thank you for spending some of your Sunday afternoon with us. We know you could have spent it otherwise. So we do appreciate your spending some time with us to keep pace with what is happening in sports medicine, especially regarding long COVID and athletes and so on. I'm going to go ahead and close the presentation, close the chat, close the Zoom in perhaps about 5 minutes if anyone needs to say anything else. We sent on information in terms of registration, and for those who need to pay, all right, for those who need to pay for the CMEs, you can go ahead and pay almost any time. You don't need to actually pay immediately. And of course, we sent our contact information for those who need that. So again, without anything further, Mr. Miller? Nothing else?
That's it. Just stay tuned for another exciting keeping pace in 3 months' time.
Yes, thank you. Thank you very much. Yeah, in 3 months' time, so that's June, the central branch of the JSM will be putting on their keeping pace. So definitely keep everyone abreast of that. So thank you again to everyone. And by the way, thank you to the rest of the education committee for your support, as usual. And well done. Good job.
Bye.
Take care, everyone.
All right, take care, everyone.
Thank you. Have a good Sunday evening, all.
Yes, thank you, Dr. Baker.
Hi, thank you.
Thanks for having me.
Thank you for
Good presentation.
Thank you.
Good. Thank you, everybody.
Mental health in elite athletes.
Okay.
That's
okay. That sounds interesting. That's the next topic for our next keeping pace.
I guess so. Oh, I see that. Yes. And I'm here, bro. Thank you very much. Thank you.
Okay.
Thank you for kind of teasing us with that.
All right.
All right. Looking forward to it. All right, gonna go ahead and end the meeting. So thanks everyone. See you soon.
Bye.